Chapter 37 discusses disorders of gastrointestinal function. So some of the signs and symptoms that are really common to a lot of the gastrointestinal disorders are anorexia, nausea, and vomiting. So anorexia is just this overall loss of appetite or just inability to eat or feel like eating. Nausea is described as an unpleasant and subjective experience with many possible causes. So you can see that over here. There's a lot of causes of things like nausea and vomiting, which is that expulsion of stomach contents. They can be external causes like motion sickness or alcohol poisoning, food poisoning, or different medicines. Or they can be internal causes. Some people get nausea and vomiting from headaches or from viral infections. Heart attacks can also do this, as can severe pain from really any source. There can also be abdominal sources, so things like appendicitis, hepatitis, kidney disease, gallbladder issues, and pregnancy is another common cause of nausea and vomiting. So that's just sort of a description of these very, very common signs and symptoms that we see a lot in different gastrointestinal disorders. So anorexia, nausea, and vomiting are physiological responses, again, that are common to many GI disorders. So retching is another one, and retching is this rhythmic spasmodic movement of the diaphragm, the chest wall, and the abdominal muscles that may or may not result in expulsion of any contents. The thing to know about these responses is that they are protective to the extent that they signal the presence of disease, and in some cases, like with vomiting, help us to remove these noxious agents from the GI tract. But they can also, if they go on long enough, start to contribute to an impaired intake or loss of fluid and nutrients. So people with these conditions, and then the longer they persist, are at increased risk of nutritional deficits as well as fluid deficits. Okay. The other thing to know about anorexia, that loss of appetite, is it can be triggered by a lot of things like drugs, things like emotions, right? Like depression and grief. Different smells can do it. And it's important to think about the wide array of things that can induce anorexia, because one of the things we may end up having to do as nurses is to find ways to help stimulate people's appetite to prevent any loss of impaired intake that related to anorexia. That could lead to things like malnutrition. So again, it's important to recognize kind of the wide-ranging list of things that can cause that. So we'll talk about the control of vomiting through different neural structures. So vomiting involves two functionally distinct medullary centers. One is the vomiting center, kind of found right here, and the chemoreceptor trigger zone, which is right here. The chemoreceptor trigger zone is located in a small area on the floor of what we call the fourth ventricle, which is kind of right here. Okay. The act of vomiting is thought to be a reflex that is integrated in the vomiting center, located in that dorsal portion of the reticular formation of the medulla near the sensory nuclei of the vagus. So there's its location kind of right there, okay? The vomiting center receives input from the GI tract and other organs. It receives input from the cerebral cortex, from the vestibular apparatus. That's probably what's responsible for things like motion sickness. And the vomiting center also receives input from that chemoreceptor trigger zone. And the chemoreceptor trigger zone, because of its location, is exposed to both blood and to cerebrospinal fluid. So it's thought to really mediate the emetic or the vomiting effects of things like bloodborne drugs and toxins. So the chemoreceptor trigger zone is activated by many drugs and endogenous and exogenous toxins that end up in the bloodstream and the CSF. Other things like hypoxia exert a direct effect on the vomiting center also and produce nausea and vomiting. And so then as the vomiting center then sends signals out to the salivary centers, the respiratory centers, and the abdominal muscles to coordinate the act of vomiting itself. Then we'll talk about gastroesophageal reflux. So this is the backward movement of gastric contents, so things that belong in the stomach back into the esophagus. It is really our most common GI tract disorder. And then we also have gastroesophageal reflux disease, or GERD. GERD is a more serious and long-lasting form of gastroesophageal reflux. It usually occurs more than twice a week for a few weeks, and it can lead to more serious health problems over time. Because with GERD, we get these symptoms of mucosal damage that are produced by abnormal reflux of gastric contents into the esophagus and into the oral cavity, sometimes into the larynx, and even into the lung. So a more serious form because it causes some kind of actual mucosal damage that can lead to long-term health problems. So the pathophysiology of GERD. In most cases, reflux is occurring during these transient or kind of short-lived relaxations of the esophagus. So we get transient relaxation, and then we also get this weak or incompetent lower esophageal sphincter. So you can see the lower esophageal sphincter kind of right here that separates the stomach from the esophagus. And if it transiently or periodically kind of relaxes and that tone is decreased, that's when we can get this refluxing of gastric contents back up into the esophagus. Other things that can cause GERD or make it worse are things like delayed gastric emptying. If the emptying of the stomach itself is slowed or delayed, it increases the volume and the pressure in the stomach itself, and that exerts this kind of backwards pressure that forces that gastric contents back up into the esophagus. GERD is broadly classified into two groups based on the endoscopic findings. So if we do endoscopy where we put a scope down to look at the esophagus itself, in some people we'll find esophageal mucosal damage, so damage to the esophageal mucosa itself. We call that erosive esophagitis or Barrett's esophagus. And some people, when we look with endoscopy, do not have any mucosal damage. So we would call that endoscopy negative reflux disease. So those people have the signs and symptoms associated with GERD, but we don't see any endoscopic damage yet on endoscopy. Esophageal mucosal injury is related to the destructive nature of the refluxate, so the fluid being refluxed out of the stomach. And it's also related to the amount of time it is in contact with the mucosa. So the longer that gastric secretion remains in contact with the mucosa, and the kind of volume and acidity of it are what are going to determine how much mucosal damage occurs in GERD. So the clinical manifestations of GERD include things like heartburn, which is this kind of retrosternal burning behind the sternum, as well as regurgitation, where someone has this perception of refluxed gastric contents within the mouth. They most frequently occur and their highest level of severity happens about 30 to 60 minutes after eating. So sometimes we ask patients about timing of heartburn to determine cause. And the symptoms are usually worse when someone is bending over or in like a recumbent or lying position, because that makes it more easy for that gastric content to kind of reflux back up into the esophagus. We also see these symptoms occur more often at night. This is because of two reasons. One is because people are typically more recumbent at night. And also we may get more kind of relaxation of that esophageal sphincter at night, allowing that refluxing to occur. People also might experience things like frequent belching or chest pain. It may also precipitate or make worse signs and symptoms of asthma. People can also develop a chronic cough or laryngitis. It can cause injury to the mucosa of the esophagus itself, which can lead to something called strictures, which are kind of like these like closures or narrowing of the esophagus itself. And it can also lead to something called Barrett's esophagus, where we see the cellular metaplasia or changes to the cells within the esophagus itself. And Barrett's esophagus is important because the presence of Barrett's esophagus increases the risk of the development of esophageal cancer. Other things that I didn't mention already in the clinical manifestations that you can see here are also things like trouble swallowing and eating normally. So especially if someone is developing things like esophageal strictures, that's going to impair swallowing. And we also see people develop increased risk of tooth decay because of that refluxing of gastric contents all the way back up into the mouth that starts to erode the teeth. So diagnosis and treatment of GERD. We usually diagnose this based on physical exam and history taking, looking for reflux symptoms. We can also diagnose using something called an acid suppression trial. And essentially what we do is just give someone a PPE for like a week or two and just see if their symptoms go away. And if it does, then we can kind of confidently say that this is being caused by refluxing of gastric contents. We can also do esophagoscopy, where we look at the esophagus itself with a camera. And we can also do esophageal pH monitoring. So to monitor pH, we pass an electrode into the esophagus to monitor data. The device allows the person to indicate like different position changes, like when they're having meals and their heartburn symptoms. And then we can correlate those things kind of back to episodes of acid reflux. Treatment of GERD, largely the treatment is lifestyle changes, so we really focus on that a lot. So we tell people to avoid positions that would increase their symptoms, right? So don't be recumbent. If you're asleep, maybe prop the head up with pillows. Sit upright, after eating. No like bending or lying down directly after eating. We would tell people to avoid large meals because all of that kind of increase in volume within the stomach can increase the pressure and force more reflux. We tell patients to avoid anything that could further reduce the tone of the esophageal sphincter. So that's things like the ingestion of caffeine or alcohol. Other things that can do that are chocolate, or smoking. So we want people to not smoke. Avoiding anything that might be considered a heartburn trigger. So things with like a lot of acid in them, like citrus fruits or vinegars or like tomatoes might need to be avoided. People might do better if they're wearing like maybe more loose and comfortable clothing to reduce any kind of like pressure buildup within the stomach. Regular exercise can also help. Chewing your food really well and chewing slowly can help to like kind of minimize that sort of slow gastric outflow. So those are, kind of the lifestyle changes. A lot of people do take medications for GERD, things like antacids or H2 blockers or PPIs, and those work really well. But I'll also say that we encourage patients to make significant lifestyle changes as well because the medications work much better and patients have much better symptom control if they combine lifestyle changes with the use of medications. Then we're going to talk about esophageal cancer, cancers that form within the esophagus. There are two types of esophageal cancer. There are squamous cell types and adenocarcinomas. Clinical manifestations of esophageal cancer include things like difficulty swallowing, the presence of frequent hiccups, unintentional weight loss, chest pain or discomfort, or a persistent cough. Patients also develop fatigue or pain or discomfort in the back of the throat, and they may regurgitate food or liquids when they eat. Squamous cell esophageal cancer is the most common in patients who maybe drink alcohol or use tobacco. So those are some of the kind of big risk factors for the development of squamous cell esophageal cancers. And adenocarcinoma types are usually the type that are due to Barrett esophagus changes that we see in patients with GERD. Treatment of esophageal cancer really depends on the stage at diagnosis. So we can surgically resect the areas of cellular change within the esophagus. We can use like different kind of like ablating therapies to destroy those tissues as well in really early stages. We want to identify Barrett's esophagus early and aggressively treat GERD to prevent esophageal cancers. We can also use radiation and chemotherapy for more advanced stages or for esophageal cancers that have metastasized, specifically with the use of chemotherapy. The prognosis for esophageal cancer is really quite poor. Patients often have metastasis at the time of diagnosis, so really advanced disease before we know it's there. And the treatments of esophageal cancer are often really pretty painful, and they have pretty significant effects on people's quality of life. So things like esophageal resection means that that patient isn't able to eat normally, which can really, decrease quality of life. All this regurgitation of food can cause injury and things to the lungs and trouble breathing. So esophageal cancer is a very difficult cancer both to live with and to treat. So next we're going to talk about the gastric mucosa itself, kind of the protective lining that we have within the stomach that's necessary because of that high acidity environment that we see there. So the stomach lining itself is usually impermeable to the acids that it secretes. So we don't want those acids to permeate or be kind of reabsorbed into that stomach lining. And that property allows the stomach to contain these really high levels of things like acids and pepsins, which break down the stuff in the stomach, without going ahead and digesting the stomach wall itself, right? So we have all these things in the stomach so that we can digest our food, but we don't want those digestive enzymes and those acids to break down the stomach lining itself. So we have this gastric mucosal barrier, which is our impermeable epithelial cell surface covering. Within that gastric mucosa, there are also mechanisms for the selective transport of things like hydrogens and bicarbonates. So you can kind of see that in the picture here. We have the submucosal layer where we have all of our kind of blood supply. We have the epithelial layer, and then we have the mucus layer. And the pH of this space sort of between the epithelial and the mucus layers is usually about 4.4 to 6. So we compare that to the pH within the lumen or the inside of the stomach, which is much lower, much more acidic, usually a pH of 1 to 2. And so if that really low pH, in addition to all the pepsin, was directly contacting this epithelial layer, it can start to just break down and erode that epithelial layer. And we'll see that happen in some patients, and we'll talk about that with some of the disorders of the gastric area. But that mucosal layer is really important to protection from that really low pH. The other thing that you can see is these hydrogen and bicarbonate ions traveling through here. And so that helps to maintain that kind of lower pH at that epithelial layer. So we have some bicarbonate that lives within that mucosal barrier itself to kind of help buffer. We also have this PGE2 refers to prostaglandins, which are another kind of important substance that we see in that mucosal layer that we'll kind of talk about. So the different types of mucus that are protecting that gastric mucosa. On that kind of inner surface, we have this water insoluble mucus, and it forms a really thin, stable gel that adheres to the gastric mucosal surface itself. And it provides protection from the proteolytic or the protein digesting action of pepsin. So we have all this pepsin kind of floating around within the stomach itself. And this water insoluble mucus helps to protect the stomach lining from being digested by it. And it also traps things again like bicarbonate, and that helps to form this alkaline interface between the luminal contents of the stomach and the mucosal surface itself. So it helps to buffer kind of directly. And then we have our water-soluble mucus, and that is this mucus layer right inside of the stomach that's kind of washed away sort of continuously from the mucosal surface. And that mucus like kind of combines and mixes itself directly with the luminal contents or the contents within the stomach. It's really viscid in nature and it acts as sort of a lubricant that helps to prevent any mechanical damage to the mucosal surface. So if there's anything like kind of like hard, sharp, pointy, anything that could kind of directly traumatize or damage the mucosa within the stomach, it prevents that by creating this kind of lubricating surface. So now that you know how the gastric mucosa kind of protects itself, let's talk about the major causes of things like gastric irritation and ulcer formation. So when those kind of like protective mechanisms start to break down. So if you look at the picture all the way on the left, again, this is really how that healthy mucosa looks. We have this outer mucus layer that's sort of viscous and mixes with the luminal contents, and we have this kind of mucosal layer that has like alkaline and buffering ability and transports ions, contains prostaglandins. And this helps to protect against damaging forces like gastric acidity or those peptic enzymes within the stomach. And it also has these defensive forces like, again, the surface mucus secretion, that bicarbonate secretion that we see in the mucosa itself. Good mucosal blood flow is also really protective here. It also contains this epithelial regenerative capacity to kind of keep those epithelial layers turned over and healthy. And then there's also prostaglandin synthesis within that healthy mucosa that helps to protect that barrier itself. If there's injury, like we see here, which can be caused by things like H. pylori infection, NSAID or aspirin use, tobacco or alcohol use, gastric hyperacidity, where we see all these increased acid formation in the stomach, duodenal gastric reflux, where we see reflux back from the duodenum into the stomach, or people with delayed gastric emptying, which can increase pressure inside of the stomach and also increase like the exposure to acids. All of those things can start to damage that mucosal layer. Other things that can do that are anything that causes ischemia to the that's kind of submucosal layer of the GI tract. That's again where all the blood flow is. If we get ischemia or blockage of that blood flow, it can cause damage kind of underneath. So those are both examples of either injurious exposures or impaired defenses. And if that happens, we start to erode away that mucosal layer. And now that gastric contents with its acid and its pepsins can start to necrose that underlying submucosa itself. It can cause inflammation, the presence of granulation tissues, fibrosis kind of tissues. And so that's what it looks like when we have sort of an ulceration that occurs when that normal barrier breaks down. So I mentioned aspirin and nonsteroidal anti-inflammatory drugs. Those are medications that irritate the gastric mucosa, and they also inhibit the synthesis of prostaglandins, two protective mechanisms. They can also reduce the secretion of bicarbonate, and so we lose some of that buffering activity within the mucosa. And so all those things can lead to irritation and ulcer formation. Aspirin and alcohol also can cross that lipid layer. So there's a phospholipid layer kind of between the mucosa and the submucosa. Aspirin and alcohol can cross that layer and cause damage, especially when they're taken together. So there's a much higher rate of gastric irritation and ulcer formation when people are taking NSAIDs and alcohol together. Prostaglandins, their kind of protective mechanism is to help improve mucosal blood flow and also to decrease acid secretion. They also increase bicarbonate ion secretion and they enhance mucus production. So there are a lot of protective effects happening when we have good prostaglandin release. And something like, and again, an aspirin or an NSAID inhibit that prostaglandin synthesis. And so we don't have all of those good kind of protective mechanisms of prostaglandin themselves. Other things that can cause gastric irritation and ulcer formation are infections with H. pylori. H. pylori is a bacteria that is specifically adapted to being able to thrive in that really acidic environment of the stomach. That is the only place that H. pylori can grow and multiply. But H. pylori infections can disrupt that mucosal barrier that protects the stomach from those harmful effects of digestive enzymes. And we're going to talk about H. pylori and how it does that quite a bit more in this presentation. The other issue is anything that reduces that gastric blood flow, so kind of what we see here in this middle picture, can also reduce bicarbonate kind of buffering as well. So this kind of thing happens in cases of shock. So if someone is in shock, it reduces overall perfusion, including to the GI tract. So in patients with shock or low flow states, we do a lot of aggressive kind of ulcer prophylaxis in those critically ill patients to prevent what we call like stress or shock ulcers. And we'll talk about that a little bit more. There are two different types of what we call gastritis or inflammation of the stomach, and they are acute gastritis and chronic gastritis. Acute gastritis is a transient inflammation of the gastric formation, mucosa. It's usually associated with local irritants, so things like bacterial endotoxins, which are produced by things like H. pylori, or by alcohol or aspirin and NSAID ingestion. Those are our really common causes of acute gastritis. The inflammation that these things cause is often accompanied by things like emesis or vomiting, pain, and if it's severe, it can cause things like hemorrhage and ulcerations. And the erosive forms of acute gastritis are really an important cause of acute GI bleeding that we sometimes see, or this hemorrhaging. Acute gastritis is usually a self-limiting disorder where we see complete regeneration and healing that occurs in the gastric mucosa within several days of removing whatever the inciting agent was. In addition to things like bacterial endotoxins, alcohol, and aspirin, other causes of acute gastritis can be things like oral corticosteroids, serious illness or trauma. The uremia that we sometimes see in things like kidney injury can lead to acute gastritis, as well as chemotherapy and gastric radiation. Acute gastritis can also be caused by infections that reside in food. So these are things like food poisoning. These cases of acute gastritis usually cause gastric distress and vomiting within usually about 5 hours of ingestion of food that contained that infectious agent. Chronic gastritis is characterized by the presence of grossly visible erosions and these chronic inflammatory changes. So while acute gastritis was sudden in onset with the complete healing of any kind of gastric mucosa damage, in chronic gastritis, we have these persistent areas of erosion with inflammatory changes. This eventually leads to atrophy of what we call the glandular epithelium of the stomach, so that lower epithelial layer. So you can kind of see that here in this picture, sort of deep down, these are epithelial cells covered by this gastric mucosa. So that's what it looks like normally. And if that gastric mucosa erodes away, now we start to get damage to that lower epithelial layer in the stomach itself. There are several different things that can cause chronic gastritis, but the most important type and the most important cause is Helicobacter pylori or H. pylori. So we're going to really focus on H. pylori and its effects. So again, going back to the picture, this is an H. pylori that enters the stomach and starts to infect that lining. And so it starts to multiply within that really acidic environment in the stomach, and further attacks that gastric mucosa until it really erodes it away. And as that gastric mucosa erodes, it causes inflammation or gastritis. So you can see that in the picture here, where we have this kind of overall inflammation of the stomach lining itself. and it can start to cause ulcerations or erosions that will not heal within that stomach lining. So with Helicobacter pylori, it colonizes the mucus-secreting epithelial cells of the stomach. H. pylori also produces enzymes and toxins that have the capacity to interfere with the local protection of the gastric mucosa against acid. They produce this intense inflammatory effect of those epithelial cells, and they also elicit a strong immune response, which further contributes to that inflammatory process. So diagnosis and treatment of H. pylori, some of the diagnostics we use something called a C-urea breath test using these radioactive carbon isotopes that can pick up the presence of H. pylori. We can also do a stool antigen test, so antigens to H. pylori can show up in the stool. And we can also do an endoscopic biopsy for detecting something called urease, which is produced when H. pylori is present. Other possible tests, we can do serum or blood tests to obtain titers for H. pylori antibodies. So any of those things can be used to diagnose the presence of H. pylori. H. pylori is very common. We treat it with a combination of therapies that includes antibiotics or bismuth salts combined with PPIs, but it's very difficult to eradicate. As we mentioned, things like chronic gastritis can eventually lead to the formation of peptic ulcers. So peptic ulcer is ulcerative disorders that occur in areas of the upper gastrointestinal tract that are exposed to acid and pepsin secretions. So over time, that chronic gastritis erodes away that mucosal barrier. And now we've got acid and pepsin that are directly contacting that endothelial lining in the stomach, and that leads to these ulcerations. We see ulcerations in the stomach themselves. We call those gastric ulcers. And we can also see ulcerations in the duodenum. We call those duodenal ulcers. Spontaneous remissions and exacerbations are really common with peptic ulcers, where patients have, very few clinical manifestations followed by periods of a lot of kind of clinical manifestations. So during an exacerbation, pain usually occurs daily for a period of several weeks, and then it can remit until the next recurrence. Another characteristic of the pain that we see during these exacerbations is that the pain is often relieved by things like foods or antacids. So if we can reduce the acid within the stomach or, feed someone to kind of create a new barrier, we can reduce some of that pain that we get with peptic ulcers. Some common causes of peptic ulcers, anything that can cause significant or chronic inflammation to the mucosal, that lining itself, right? So H. pylori is a very common and important cause of peptic ulcer disease, as are things like aspirin or NSAIDs. We also see incidence of this increase with age or with warfarin use, and we see higher rates of peptic ulcer disease in patients who smoke. So the etiology and the pathogenesis. So again, most common causes are H. pylori and the use of aspirin and NSAIDs. And they impair the gastric mucosa protection, and that leads to gastric injury. Again, so you can kind of see that in the same picture. So the other thing to know is that if someone is taking NSAIDs, the concomitant or the presence of H. pylori increases risk. So if we have multiple risk factors all at the same time, we have much higher incidence of peptic ulcer disease formation. So the clinical manifestations of what we call an uncomplicated ulcer, so just a regular ulcer that we haven't seen any other significant complications form. So the most common complication is just pain. And this pain is usually burning and gnawing and cramp-like. It frequently occurs when the stomach is empty or between meals, and is also really common at night, usually like maybe around 1 or 2 in the morning, where this pain will like wake somebody up from sleeping. The pain is usually midline, like in the epigastric area or near the xiphoid process. It can also cause things like voluntary muscle guarding with extensive lesions. It occurs or recurs, excuse me, at intervals of weeks or months, and it's usually relieved again by food or antacids. There are some things that can become complications of peptic ulcer disease, and one important complication is hemorrhage. And this is caused by bleeding from the granulation tissue or from the erosion of those ulcers into an artery or a vein within that submucosal layer. So if you remember way back to that picture in that submucosal layer, we had a lot of blood vessels that flowed through there. If we erode deeply enough through those linings and we erode into an artery or a vein, then we can have bleeding from these ulcers. That bleeding can be either acute or chronic, and it often leads to secondary hospital admissions and peptic ulcer from things like anemia, especially from chronic forms. Bleeding can also be sudden, where you have someone with what we call coffee ground emesis, where they're vomiting up this kind of like stuff from the stomach that looks like coffee grounds. So it's gastric contents like mixed in with blood that gives it that kind of distinct sort of appearance. Another complication of peptic ulcer can be obstruction, and this can be caused by edema within the stomach. It can be caused by spasm of the muscles within the stomach, or contraction of scar tissue that interferes with the passage of gastric contents through the pylorus or adjacent areas. So you can kind of see that here, right? There's this space between the stomach and the duodenum, and if that area becomes inflamed or swollen, or if a lot of scar tissue forms here, it narrows that passageway and can lead to an obstruction of the movement of gastric contents out into the duodenum. So the presentation of an obstruction is usually pretty insidious, so kind of slow growing over time. The symptoms that we see are things like early satiety, where someone, eats a very small amount but feels very full. They also might get this feeling of kind of this epigastric fullness or heaviness, especially after meals. They might have gastroesophageal reflux. They may lose weight and experience abdominal pain. If that obstruction becomes very severe, patients can start to vomit, especially this vomiting of like all this sort of undigested food, because it just doesn't have really anywhere else to go. So the only thing left is to kind of vomit it up, right? Another complication of a peptic ulcer is a perforation, and this occurs when an ulcer erodes all the way through all the layers of the stomach or through the duodenal wall. And you can see that here, where we have a complete erosion through all of those layers of gastric tissue. And if we get a perforation, then we get stomach contents that are leaking out into the peritoneum. And this can cause a condition called peritonitis, or inflammation of the peritoneal cavity. This condition has a relatively high mortality rate, especially if that perforation occurs in older adults. So this is a very serious potential complication of peptic ulcer disease. Another potentially serious complication is something called penetration. And this is where that ulcer crater starts to erode into an adjacent organ. It can erode into the pancreas, into the liver, or into the biliary tree or gallbladder. So you can see that kind of in the pictures here, where that ulcer has penetrated all the way through and has started to erode into adjacent organs. So whether or not that occurs and what it erodes into really depends on where within the stomach that ulcer happens, and what sort of adjacent organs might be in that area. Another thing that can happen within the gastrointestinal tract itself is gastrointestinal bleeding. This can take the form of what we call hematoemesis, where we have blood within the vomit. It might be bright red if there's a lot of bleeding that's really sudden and acute, or it can have what we referred to earlier as that kind of coffee ground appearance. And that's usually slower bleeding, where the blood has had time to kind of sit within the stomach contents itself, so it doesn't have that kind of bright red appearance anymore, but because we've had some kind of like breakdown and digestion of the blood itself. Other ways that we can find gastrointestinal bleeding are in melena, and that is blood in the stool. And often what we'll see is changes to the color of the stool itself. It can be bright red blood, especially if that bleeding is really low in the gastrointestinal tract, or it can be tarry black. And that's again when we have maybe bleeding higher up in the GI tract, and so there's been a lot of breakdown and change to that blood as it passes through. It may also be what we call occult in nature, where it's hidden, where there is no visible presence of blood. And we would need to test for that using an occult or a guaiac stool test. So treatment of peptic ulcer, we really want to try to eradicate the cause of the ulceration and to really promote a permanent cure for that disease. So whether it's eradicating H. pylori or relieving the symptoms of the ulcer or healing the crater itself. So to heal the crater, we might use things like acid neutralizing or acid inhibiting drugs that will lower the GI acidity and reduce kind of the attack and inflammation on the epithelial lining. We can also use medications that are mucosal protective. There are some meds that actually kind of coat or bind themselves to the stomach lining itself that can help protect. Antacids are really helpful to reduce acid, as well as proton pump inhibitors. But again, really, if we have someone with peptic ulcers caused by H. pylori, we really want to try to eradicate it, which, as I mentioned earlier, has proved to be really difficult. So, again, the best treatments we have there are these combination therapies of things like antibiotics with bismuth salts combined with PPIs to lower acid. So that's really the treatment of H. pylori. But if it's other things like NSAIDs or corticosteroids, we may stop taking those. We usually recommend, to reduce or eradicate any alcohol intake. Stop smoking, right? Take away any of the potential causes of that peptic ulcer formation. As we mentioned earlier, we also have patients who can develop what we call stress ulcers. And these are often ulcers that are caused by like a reduction of either bicarbonate formation that helps to buffer the mucosa, or from disruptions in blood flow to the GI tract itself. So some risk factors for these are things like large surface area burns, extensive trauma, sepsis, acute respiratory distress syndrome or ARDS, severe liver failure, major surgical procedures, or something called Zollinger-Ellison syndrome. And Zollinger-Ellison syndrome is a really rare condition, but that's caused by a gastrin-secreting tumor within the stomach, or what we call a gastrinoma. So in those patients, they have this tumor that's secreting all this acid, which creates these really highly acidic environments. So now we're going to move on from the stomach to intestinal function, and we're going to talk about the conditions that cause alterations in intestinal functioning. So these are things like irritable bowel disease, inflammatory bowel disease, and we're going to really focus on those two things, as well as appendicitis. And those are really the three conditions we're going to focus on in this presentation. There are also things like diverticulitis, alterations in bowel motility, malabsorptive syndromes, and cancers of the colon and rectum. So we're going to start with irritable bowel syndrome. Irritable bowel syndrome is termed something called a functional disorder because in IBS there are no structural changes within the GI tract. There's no visible damage. If you looked at the GI tract of someone with IBS and someone without it, they would look the same. There's no structural change, no visible damage. So the diagnosis of irritable bowel syndrome is done entirely based on symptoms alone. Those symptoms are things like persistent or recurrent symptoms of abdominal pain. They also get a lot of altered bowel function, and that can take the form of both constipation and diarrhea. They're often very bloated, and they also experience an increase in things like flatulence or gas. They also have an increased incidence of nausea and vomiting. And there's also a direct link. A lot of patients with IBS also have conditions like anxiety and depression. They may also, in some cases, experience things like headache with their symptoms or backaches. And the loss of appetite can also be relatively common in IBS. The treatment of IBS really focuses first on methods of stress management. Again, we see a really direct link between stress, anxiety, and depression and the development of IBS symptoms. So managing stress and then those other kind of comorbidity mental health symptoms can really be helpful to reduce IBS symptoms. Um, Usually, no special diet is indicated, although for some people, reducing fiber intake can be helpful. There are other people who, for avoidance of certain offending dietary substances, might be helpful. So, some things might include like high fat foods or foods that produce a lot of gas. The elimination of alcohol and caffeine might be really helpful. We also have some medications that can sometimes help. So things like antispasmodic agents or anticholinergic agents have had some success with treating IBS signs and symptoms. Then we'll talk about the inflammatory bowel diseases, which are Crohn's disease and ulcerative colitis. Crohn's disease is a recurrent granulomatous type of inflammatory response that can affect any area of the GI tract, anywhere from the mouth to the anus. So this is Crohn's disease here, and you'll notice that there are lesions that appear throughout the GI tract in this case. A granulomatous type of inflammatory response is characterized by a collection of immune cells, like macrophages, that cluster together in this GI tissue to form what we call granulomas. And we often see those as a symptom of chronic conditions, as in the case of Crohn's disease. Ulcerative colitis is a nonspecific inflammatory condition of the colon. So the inflammation that we see is not the same as what we see in Crohn's disease in the type, nor is it the same in location. And so in ulcerative colitis, usually we see this inflammation on kind of the left side or in the descending colon and in the rectum only. So the etiology and pathogenesis of inflammatory bowel disease. So usually involves a failure of immune regulation combined with a genetic predisposition and some sort of environmental trigger. So we have this unregulated and exaggerated immune response that is causing this inflammation within the lower GI tract. There is a strong predictor within family history of IBD, which is how we know that there's a genetic predisposition here. And we also have identified a few potential environmental triggers. So smoking increases the likelihood that someone will experience IBD. And we also have linked antibiotic use. So patients that have used antibiotics recently, sometimes we see IBD formation, or patients who have used antibiotics a lot in the past for like recurrent issues have higher incidence of the development of IBD. So the clinical manifestations of inflammatory bowel disease, one is that we're going to see in some form these inflammatory damage or lesions to the tissues themselves. Most of the time, IBD has periods of remission and exacerbations. And exacerbations usually have signs and symptoms like diarrhea or this fecal urgency combined with weight loss. Other things that we see in these patients, they can develop things like intestinal obstructions. And we also see systemic manifestations as well. So things like arthritis, often of like the spine or sacroiliac joints. They also can get inflammatory conditions of the eyes and lesions on the skin. We also see things like autoimmune anemia and hypercoagulability. And if we have IBD conditions in children, because of the reduction in their nutritional intake, we often see growth retardation or slowing in children with IBD conditions. But I will say there are some significant differences between the clinical manifestations we see in Crohn's disease versus ulcerative colitis. So it's going to be important to kind of know the difference in what we may see and what complications may manifest themselves depending on the type of IBD someone is diagnosed with. So with Crohn's disease, again, these are characterized by those granulomatous inflammatory lesions. The lesions that we see extend into the submucosal layers of the GI tract. And so here's the GI lumen, and the Crohn lesions will extend all the way down into this submucosal layer, which is the last layer before the muscle layer of the GI tract. These lesions are primarily found in areas of the ileum and then secondarily in the colon. But again, remember that these lesions can occur anywhere within the GI tract. Diarrhea is really common, but rectal bleeding is pretty rare. Fistula formation, stricture formation, and perianal abscesses are also really common. And we'll talk a little bit more about fistula and stricture on the next slide. Usually patients with Crohn's disease don't have an elevated risk of cancer, however. That development is relatively uncommon. So a little bit more about Crohn's disease and its specific clinical manifestations. So this is characterized by something called skip lesions. And so they have very distinct lesions that are interspersed, with very distinct demarcation that are interspersed with areas of healthy GI tract. So that's what we mean by skip lesions. But they again extend through all the bowel layers into those submucosal layers. And over time, the bowel wall starts to thicken and become really inflexible. Fistula formation can happen between different segments of the GI tract, or it can happen between the GI tract and the bladder, GI tract and vagina, GI tract and urethra, or GI tract and the skin. And so you can see in the picture here, this is kind of a fistula formation where we get this communication between an area of the GI tract where one of these skip lesions has formed and another portion of the GI tract itself. And so now these two areas are communicating, right? And if it's GI tract to GI tract, not a great thing. We often have to surgically repair them. But if it's between another structure like the bladder, vagina, urethra, or skin, now we've got GI contents leaking into an area where it doesn't belong, okay? You can see also in this picture, again, this is the skip lesion nature of it, where we have this clear demarcation between healthy tissue and diseased tissue. We can also get extension into the lymph nodes in Crohn's disease, so that's something that's kind of relatively common. This here is one of what we talk about, those granuloma type lesions that are real distinctive for Crohn's disease. There's this kind of transmural, like chronic inflammation that's very common in Crohn's disease. This here looks like a kind of like a perforation out into other areas of the peritoneal cavity as well, which we can sometimes see with Crohn's disease, again, because of how deeply that inflammatory process extends into the GI tract. The principal symptoms are often dependent on the area of the GI system that is affected, but usually it's things like diarrhea, abdominal pain, weight loss. They can also get fluid and electrolyte disorders, general malaise, and low-grade fevers, especially if there's a lot of inflammatory process happening. So diagnosis and treatment of Crohn's disease. Diagnosis is often started with a good extensive history and physical examination. We could also do sigmoidoscopy, where we insert a scope into the GI tract to visualize the GI tract itself and to potentially extract tissue for biopsy to look for those kind of distinctive granulomatous lesions from Crohn's disease. We can also do radiographic studies with contrast to sort of look for the extent of areas of involvement and also to maybe visualize whether or not we have fistula formations. There's really no cure for Crohn's disease, but we can hopefully get people into remission where they have a very low level of clinical manifestations. So the overall goals of treatment are to terminate the inflammatory response, and we have different medications, different sometimes steroidal medications. There are some like DMARDs have been proven to work pretty well to reduce inflammation. So those are some of the ways that we might try to do that. And then we also want to try to promote healing of those inflammatory lesions themselves while maintaining nutrition and preventing any other complications, again, like fistula, stricture, any of those other things, perforations that can go wrong. We can also do surgical procedures, and some patients with severe Crohn's disease undergo quite a few surgical procedures throughout their lifetime. So this might be the need to like resect severely damaged areas of bowel, or to repair fistulas, or to drain abscesses that may form within the GI tract. Sometimes as far as treatment, there are some conservative measures that might help as well. So maybe like low-fat diets that are high in calories, vitamins, and proteins. Patients who are experiencing an exacerbation may benefit from low bulk diets. So really like maybe low fiber diets might help to reduce symptoms. For patients with really like maybe a severe exacerbation where they're having trouble getting in nutrients at all, we may have to use total parenteral nutrition where we give nutrition entirely through the veins in those patients for a short period of time until maybe we get enough healing to have good absorption from the GI tract. Then we're going to look at ulcerative colitis. And so some of the characteristics of UC are inflammation that is ulcerative and exudative. It primarily involves the mucosal layers. So just kind of these first mucosal layers outside of the lumen. So not quite as deep of a penetration into the deeper layers of the GI tract as what we saw in Crohn's disease. The lesions are usually what we call continuous in nature and involve the rectum and left colon. So we don't see those kind of skip lesions where we have healthy tissue, diseased tissue. They're usually just one long continuous lesion. Diarrhea and rectal bleeding are relatively common in UC, but the formation of things like fistulas, strictures, and perianal abscesses are relatively rare, probably because, again, they don't extend as deeply into the layers of the GI tract. But cancer development in patients with UC is much more common in this case. So again, UC is really limited to the mucosa and submucosa of the colon and rectum only. The cause is really unknown, but it's probably some sort of systemic autoimmune cause. The characteristic lesions form in an area called the crypts of Lieberkühn. So that's very distinctive for UC. Over time, the bowel wall starts to really thicken in response to these repeated inflammatory episodes of UC. And there is a relapsing, remitting nature to it, marked by these serious attacks of diarrhea that contain blood and mucus. So other signs and symptoms of UC are things like anorexia, fatigue, and weakness. There are different levels of severity of UC, ranging from mild to moderate to severe, or all the way up to fulminant. And these are really dependent on how much of the colon is affected, so how much inflammation there is, as well as the frequency of diarrhea and the presence of systemic manifestations. So you can see here, this is a colon that has ulcerative colitis. So you can see like kind of this inflammatory condition forming here. And a lot of the inflammation with UC takes the form of these kind of like pseudo polyps. They have these kind of like inflammatory, like finger-like projections out into the colon. So that's pretty uh, indicative. They can also get something called toxic megacolon, where we get this like big sort of like outpouching in the colon itself that kind of stops the movement of gastric contents through, and they can just sort of sit here and cause things like sepsis. Perforation can also occur with UC, where we get gastric contents leaking out in the peritoneum, as well as hemorrhage, where we get inflammation down to the level of blood vessels that causes bleeding. And as I mentioned, also an increased incidence of colon cancer. The systemic or the extraintestinal manifestations we sometimes see with UC are arthritis, and I have that highlighted because that's probably the most frequent extraintestinal manifestation. They can also get uveitis, which is inflammation of the eyes, deep vein thrombosis, primary sclerosing cholangitis, which is a disorder of the gallbladder, or something called ankylosing spondylitis, which are changes to the vertebral columns. So diagnosis and treatment of people with UC. So history and physical exam. We can also use sigmoidoscopy or colonoscopy to directly visualize the GI tract, or biopsy to take a look at stools and samples. Or we can look directly at the stool itself, looking for the presence of mucus and blood. Colonoscopy, though, is really contraindicated in anybody with severe disease because there is an increased chance of perforation during that procedure. For treatment can be really conservative, maybe just dietary treatment for people with mild to moderate UC. People with mild to moderate symptoms are often able to control their symptoms by doing things like avoiding caffeine or the lactose in milk, or maybe not eating highly spiced foods or gas-forming foods. Sometimes fiber supplements can help to decrease diarrhea and some of the rectal symptoms. People with more severe forms, like the severe UC or the fulminant types, may end up needing surgical removal of their rectum and colon with ileostomy formation, especially if they don't respond to medications and conservative treatment. And then they will need more monitoring for the development of colorectal cancer because of that increased long-term risk. And finally, we're going to talk about appendicitis. Appendicitis is a very common condition. We see it more commonly in women than men. And what happens here is the appendix, which is this little tiny kind of like vestigial, like unnecessary organ or outpouching coming off of the colon, becomes inflamed. And as it becomes inflamed, it can become swollen and gangrenous. And if it's not treated with removal, it can become so swollen and gangrenous that it can perforate and start to leak gastric contents out into the peritoneum, causing peritonitis. Appendicitis is usually caused by intraluminal obstruction with something called a fecalith. So a hard piece of stool gets sort of lodged here, and that prevents anything from being able to leave the appendix. Other things that can block it are like gallstones or tumors, parasites, or lymphatic tissue can block that kind of outflow of the appendix itself. So appendicitis usually presents as right lower quadrant pain, and it's characterized by nausea and something called rebound tenderness. So if we press down into the belly, as that depression of the stomach or of the abdominal wall itself is removed, the pain will actually increase. So that pain is really related to stretching caused by inflammation of the appendix itself, and usually has a really abrupt onset. So the abrupt onset of right lower quadrant pain with rebound tenderness is very indicative of appendicitis and needs really kind of rapid, almost emergent treatment to remove the appendix. If we can remove the appendix before rupture occurs, usually we do that laparoscopically. It's a very simple procedure to just remove the appendix, and patients usually recover really quickly from that appendicitis. If we don't remove the appendix quickly and the appendix itself ruptures, then someone might develop appendicitis with peritonitis, that inflammation of the peritoneum, that can cause long-term complications like infection and inflammation. They might need to be hospitalized for an extended period of time with total bowel rest. They might end up going on things like TPN. They might need long-term antibiotic therapy. So much more serious condition if we don't remove the appendix before it ruptures.